Right, good morning everyone. Today's my presentation is on Talus fractures. So an overview of my talk, I'll go through the anatomy, classification, presentation, assessment, management, surgical approaches, complications and the outcomes of Talus OrthoFracs. So a bit about the anatomy. The talus is a complex bone which makes fracture fixation difficult. It has a complex osteology. There are multiple articulations. There's a tenuous blood supply. A large portion, about 60% of its surface, is covered with articular cartilage. It's constrained within the ankle mortise, making it difficult to access, and it has no muscular or tendinous attachments. The talus is broken down into the body, neck, and head. The body contains the talar dome, which is wider anteriorly than posteriorly, making it more stable in dorsiflexion. It articulates with the tibial plafond, the distal tibia, and the calcaneus. The neck projects from the body medially and plantally, and the head articulates with the navicular. There are also two processes, the posterior process, which extends posterior medially from the body. This has two tubercles separated by a central sulcus, which is where the FHL tendon passes. The lateral process extends inframedially from the body. Looking at the inferior surface of the talus, there are three facets which articulate with the calcaneus and form the subtalar joint. There is a groove that divides the anterior and middle, and a groove between the anterior middle and the posterior facets, which then forms the sinus tarsi laterally. Looking at the blood supply, it's quite a complex blood supply. The majority of the supply comes from the posterior tibial artery, followed by the anterior tibial artery and a small portion from the perineal artery. There are anastomosis between the anterior and posterior circulation with the artery of the tarsal sinus and the artery of the tarsal canal. Historically, it is thought that there was a retrograde flow to the body, but there's new evidence to suggest that there's a robust anterograde flow as well. So just roughly breaking it down, you can see the popliteal artery, it splits into the anterior tibial artery, the posterior tibial, and the perineal artery. From the dorsalis pedis artery, you can see there are medial and lateral tarsal arteries. From the posterior tibial is where we get the artery of the tarsal canal, and we get posterior branches through the posterior tubercle. The main supply from the artery of the tarsal canal is through the deltoid ligament with the deltoid artery, and then the smaller portion from the perineal artery, which gives off the perforating perineal artery, which then gives the artery of the sinus tarsi. And then there's a anastomosis between the artery of the sinus tarsi and the artery of the tarsal canal in the inferior portion of the talus. So looking at the classification, the talus fractures can be broken down into head, neck, body, lateral process, and posterior process fractures. Head fractures make up about 10% of fractures, and they can lead to talonavicular instability. The majority of talus fractures are neck fractures, and this is classified by Hawkins in 1970. About 13 to 23% of fractures that involve the body. There will be some involvement of the lateral process in about 20% of talus fractures, and an isolated lateral process injury is often seen in snowboarders, and posterior process fractures are involved in about 18% of talus fractures. So Hawkins initially described the Hawkins classification in 1970, and then Canal and Kelly added a type 4 in 1978. The classification system is for talar neck fractures, and it is classified based on nearby joint disruptions. The type 1 fractures are completely non-displaced fractures. Type 2 involve subtalar subluxation or dislocation. Type 3 have a disrupted subtalar and tibiotalar joints, and type 4 have disrupted subtalar, tibiotalar, and talonavicular joints. The most common one here is the type 2 fractures. So the Hawkins classification describes the AVN risk, and according to Hawkins, a type 1 fracture had a 0% risk of AVN, type 2 had a 42%, and type 3 had a 91%. Now these values vary dramatically in the literature, and there are wide ranges reported. It the risk of AVN increases as you go from a type 1 to a type 4 fracture. But these are some of the values that are reported, and some saying that there's even a 100% chance of AVN. The numbers on the left side are more recent values, which suggest that it's only up to maybe 55% risk. So in terms of presentation, talus fractures make up about 2% of all fractures and 3 to 5% of foot and ankle fractures. They're typically high energy trauma, and we've seen an increase in talus fractures, not due to them becoming more common, but that there being an increased survival from motor vehicle and motorbike accidents. There's a very high incidence of ipsilateral extremity injuries of about 50%. 18 to 25% of fractures are open fractures. There can be a concomitant medial malleolus fracture in about 28%. And they can also be missed, so reportedly 6.9% of fractures are undiagnosed at the time of presentation. Classically, it's an axial load. So in the case of a motor vehicle accident, it can be that the foot is forced into dorsiflexion and varus with the braking foot. This often results in the talar neck fractures. There will be medial comminution, where the bone fails in compression, and less comminution on the tension side, which is laterally. They can also occur from falls from heights, and this more results in the talar body fractures. The lateral and posterior process fractures are the types of fractures that occur more commonly, or that can occur in the low energy injuries. And as I said, the lateral process fractures are also known as snowboarders fractures because of the dorsiflexion and eversion. In terms of your assessment, these patients, due to the high energy, should be assessed according to your EMST principles. It's really important to do a thorough evaluation of the skin and neurovascular status, and consider the possibility of ipsilateral lower limb fractures and spine injuries. In terms of your investigations, you should start with plain film x-rays with standard routine foot and ankle series. There is also the canal view, which is a true AP of the talar neck. It's not so much used in diagnosis, but more intraoperatively in terms of your fixation. It's taken with the foot in 15 degrees of pronation and 75 degrees from the horizontal. CT is useful because of the sensitivity of x-rays is only about 75%, and CT can help identify, clarify, and inform the surgical planning. In terms of your initial management, it's very important to get urgent reduction of any dislocations. This can be done as a closed reduction in the emergency department, or more commonly in theatre. It's advised that you should have no more than 2 or 3 attempts at closed reduction before proceeding to an open reduction. It can often be that there's interposed soft tissue that can prevent a closed reduction. In the case of open fractures, patients should of course have ADT and IV antibiotics. With an extruded talus, there should be immediate irrigation with normal saline, and the aim is to reduce the talus back into the wound. This may likely be done in theatre rather than the emergency department. Then the case is whether, because of the soft tissue injury, it's likely that you'd perform a ankle spanning X-fix plus or minus K-wiring of the unstable joints. Traditionally, it was thought that definitive fixation should be performed urgently. However, it's not been proven now to be associated with the risk of AVN, and the timing of definitive surgery can depend more on the soft tissues. So non-operative management is reserved only for the undisplaced or small fragment and extra-articular fractures. In this case, the patients can be made non-weight bearing in a below-knee cast for a minimum period of 6 to 8 weeks, and likely followed by a period of protected weight bearing in something like a cam boot. Indications for surgery involve any displacement or malalignment. There's evidence to say that only 2 millimeters of displacement on talar neck fractures can result in increased contact pressures in the subtalar joint and increase the risk of subtalar arthritis. And varus malalignment of the talar neck also reduces the subtalar mobility. I'll go through the surgical approaches that are most commonly used, so the anterolateral, anterior medial, and the posterior medial. Goals of the surgical management are, of course, to establish joint congruity and stability. It's important to achieve the medial column length and height. remove any loose fragments, and as I said, it's important to protect the soft tissues, so timing of theatre is important. So looking at the anterolateral approach to the talus, so this is done in line with the fourth ray. It's between the peroneus tertius and brevis. The structure at risk here is the peroneal nerve, which must be protected. You then need to elevate the sinus tarsi fat pad and the extensor digitorum brevis muscle from its origin to access the talus. From the anteromedial approach, this is between the tendons of tibialis anterior and tibialis posterior. This approach can be extended proximally to involve the medial malleolus if requiring osteotomy or fixation. And structures at risk here are the saphenous vein and nerve, which needs to be protected. The posterior medial approach is for access to the posterior talar body and posterior process fractures. It's performed just medial to the Achilles tendon and lateral to the FHL and the tibial artery and nerve. So in terms of your surgical management of neck fractures, traditionally it's a dual anterior incision technique. There are multiple different fixation options. There is no evidence of superiority in either technique between dual mini-frag plates, combination of plating and screws, or positional screws alone. It's important to note that with the medial comminution, the medial-sided longitudinal screws may be contraindicated and may be more appropriate for plating. And it's recommended that you use headless compression screws to prevent the risk of any impingement. Similarly with the body fractures, traditionally it's a dual anterior approach, particularly for the anterior talar body fractures. You may need to utilise a posterior medial approach for the posterior body fractures. You sometimes may also need to perform an osteotomy of the medial lateral malleolus in order to visualise the talar dome. More commonly is the medial malleolus osteotomy. There's a lot of debate about what the best technique is. There's talk about oblique osteotomies, a step cut osteotomy or a chevron osteotomy. It's important that the osteotomy should avoid the tibial plafond, and when doing your osteotomy it's best to pre-drill prior to your osteotomy. In terms of the surgical management of head and process fractures, again, there's multiple fixation options. You can use mini-frag screws, plates, or sometimes even definitive K-wires for small fragments. If they are small and non-reconstructible, the fragments can be excised. In terms of the head, there's often impaction, which needs to be disimpacted and may need bone grafting. For your lateral process fractures, you can go via anterolateral approach, or you can do a modified sinus tarsi approach. And for your posterior process fractures, the posterior medial approach is best. Moving on to the complications from talus fractures. So there's a high risk of complications. One of the main risks is osteoarthritis. It is most commonly in the subtalar joint. Some studies have shown that this is up to 81% of patients at 2 years following talar neck fractures. Less frequently is there osteoarthritis in the tibio-talar joint, and in this case it's more commonly in combination with subtalar OA. Treatment of osteoarthritis can either be arthrodesis or arthroplasty, and the arthroplasty is really reserved for the tibio-talar arthritis, whereas the subtalar arthritis is usually treated with arthrodesis. Another significant risk is the risk of avascular necrosis. The overall rate is around 25 to 30%. This can be picked up on x-rays at the sort of 3 to 9 month mark with increased radiodensity of the talus. It's possible to diagnose earlier on MRI, however this may not actually change your management. Some of the avascular necrosis can be asymptomatic, and maybe even up to 50% may demonstrate revascularization without collapse. So the initial recommendation is for observation. There is talk of treatments of making the patient non-weight bearing, but there is not great evidence for that. And there's also the shockwave therapy has proven to show some benefit. In terms of your surgical treatment, there are joint sparing and sacrificing procedures. The joint sparing procedures involve core decompression, and there is some bit talk of vascularized bone grafting from the cuboid. There is joint sacrificing surgery, as I said, and this can involve arthroplasty with a total ankle replacement, or even some research into total talar prostheses. But there has been limited reported research of these. And then the other options is salvage procedures with arthrodesis, and this would typically be a tibio-talar calcaneal fusion. There's also a risk of malunion, and this is usually from the medial comminution, which leads to varus collapse. It is possible to perform a corrective osteotomy with bone graft, only if there is sufficient bone stock and that the joint surfaces are viable. Just an important sign is the Hawkins sign, and this is a sign where there is subchondral lucency at the talar dome. It's a reassuring sign of talar revascularization. It's usually seen between about 6 to 9 weeks on a plain film X-ray, and it's considered to reliably exclude avascular necrosis. In terms of functional outcomes following Talus orifs, one of the scores that's more commonly reported is the American Orthopedic Foot and Ankle Society score with the ankle and hindfoot score. It's a score between 0 and 100, 100 being the best score. It's both a clinician-reported and patient-reported outcome. It has points for pain, function, and alignment. And one study showing scores following ORIF for talar neck fractures demonstrated that the scores were relatively high, with the best outcomes being in the type 2 fractures, interestingly, as opposed to the type 1, which are the undisplaced fractures. If we move on to the risk of secondary surgery, this could involve things due to surgery for infection or soft tissue compromise, talus collapse due to AVN and post-traumatic arthritis. The overall rate of resurgery has been reported at 19%, but this significantly increases when you look at long-term studies, and in the study by Sanders et al., at 10 years there was a 48% risk of reoperation. All right, so in summary, they're often high-energy injuries. The patients need to be assessed appropriately according to EMST principles. They're challenging fractures due to the unique anatomy. Non-operative treatment is only reserved for the non-displaced fractures. Early reduction is more important than the timing of the definitive fixation. There's no evidence to support screw over plate fixation. The approach to your surgery will be dependent on the fracture pattern and your surgical planning. There are reasonable early functional outcomes following ORIF, but there's high risk of complications and a high risk for a need for reconstructive surgery. All right, thank you.